Hello, and welcome back to the Midland Health Podcast, healthcare that makes you proud. This is our fifth episode that we are recording here today. We're seeing a lot of traction on YouTube and podcast and Apple Podcasts where you can pick these things up, Spotify. We want to encourage people to continue to watch, but also to subscribe to the channel. That way you'll get notified when we have new episodes that are released. It'll feed into your algorithm, and it'll be at the top of your feed. So when we have something new that comes out, it's a good way to stay up to date on the podcasts that we have that are being released. We appreciate everybody's watching and being engaged and leave comments. As I've said, if there are topics you want us to cover, if there are guests that you would like to see on here, drop a comment. Let us know. We are paying attention to those things, and we'll try to build that into our plan for the end of 2026. We've got the first half of this year is about covered, and we're beginning to plan for the second half of the year. So we appreciate the engagement. Please subscribe and leave a comment. My guest today is Dr. Summer Alexander Merritt. Dr. Merritt is the founder and owner of Four Seasons Health and Wellness. That's a concierge family medicine practice here in Midland, Texas. Dr. Merritt practices old-fashioned medicine, that's in quotes, by doing home visits. She directs patients to the emergency room for emergency care. She admits and follows her patients when they are in the hospital. She keeps her practice in the 21st century by being 100% paperless, portable, and out of the realm of insurance companies, certainly as much as possible. Dr. Merritt grew up in Dallas and Longview, and she attended Austin College in Sherman. Following medical school at McGovern UT Houston Medical School in 2004, she completed a general surgery internship at Inova Fairfax Hospital in Fairfax, Virginia. Even though she matched into a categorical general surgery program, Dr. Merritt changed course after her internship and returned to Dallas to complete residency training at Baylor Garland Family Medicine Residency Program. Post-residency, she entered academic medicine and was an assistant professor of family medicine at Texas Tech University of Permian Basin in 2008. Dr. Merritt left academics and entered group practice to start her family. In 2011, she started her solo concierge practice. She is a board-certified family medicine and fellow of the American Board of Family Medicine. She has served as the president of the Midland County Medical Society and the chair of family medicine, and is currently the chief of staff at Midland Memorial Hospital. She has been a member of the Midland community since 2008. Currently, Dr. Merritt is president-elect of the Alumni Board for McGovern UT Houston Medical School, Wagner Noel Performing Arts Board, Board of Governors for the Museum of the Southwest, and Starlight Therapeutic Writing Center Board. Outside of the office, Dr. Merritt loves reading, traveling, listening to nerdy podcasts, so we're already in. She loves to watch her kid play baseball. We share that, have that in common, and equestrian riding, and spends time with her family, including her husband, 16-year-old son, 11-year-old daughter, and her 3 dogs. Dr. Merritt, welcome to the show.
Thank you so much for having me.
Really appreciate you coming with us. I thought it was really important that we have a physician on to talk about that perspective of healthcare in our community. That was a great introduction. You've done a lot. You're very ingrained in Midland, having been here for 16 years. But tell me a little bit about yourself, your role at Midland Health, and your role as a community physician, kind of in your own words.
Okay, sure. Once again, thanks for having me. And I was supposed to be here for 3 years. I think that happens to a lot of people who move to West Texas, that I made a commitment to Texas Tech to come out for 3 years and be in a teaching attending. And then very quickly after I was married, had a baby. And so wanted to exit academic medicine. I joined the practice of Dr. Joe and Carolyn Rohde, who practiced
Yep.
family medicine here for a really long time. So pretty much after joining that practice, I became involved in Midland Memorial and serving in different committees. I can't remember who got me involved. I don't know if it was Dr. Klingensmith, perhaps.
Yeah.
But then, I wanted to know what was going on at the hospital because it's vitally important to our patients, to patient care, being a part of the community. And so wanted to be more a part of what's going on administratively at the hospital. And that has, really opened my eyes. And it's quite different being in a community hospital, whereas in residency and in, surgical training and being at big academic tertiary care centers, things are a lot more bureaucratic in those places, and so being able to be involved in Midland was a lot more hands-on and having to interface, directly with ER docs, ICU docs, administration. I just thought was a really cool experience and also, really transformative in as far as how I practice medicine and how I practice medicine in the community.
Good. I think you've hit on a couple of things I've hit on in the podcast before. I've worked for-profit medical centers. I've
Mhm,
worked in a couple of other locations, and I feel like here, I hope you feel the same way in Midland and at Midland Memorial Hospital. You have a real opportunity to make a difference. There's not a lot of layers. I meet with you
mhm.
regularly. You don't have to wait and talk to four different people to try to get to the CEO or to the board.
Right.
You treat many of our board members. So while we kind of have that small time feel, our hospital is really important to the community and to the
Mhm,
region, and it's one of the things I like about my
mhm,
role is I don't have to go through a corporate office and a bunch of different people to try to get things done, and I appreciate that the role that you, but it also appreciate the kind of relationship I'm able to build with the medical staff, and my door's always open is kind of an
mhm,
old cliche saying, but people walk into my office all the time to complain
mhm,
about something that's not working well, or to congratulate us on something we did well, or bring a new recruit. Hey, I've
mhm.
got a friend. Having that kind of small town feel, I think, is what sets Midland apart, not just the community, but also our hospital. So
Right, and
thanks for saying that.
of course, and, the whole reason that I started the practice that I have now was because of one person. So it was one of my patients, her name's Barbara Duke, and at the time, that I started seeing Barbara, and anybody who knows her knows what a dynamic, hilarious, but very, involved in the Midland community and wanted our community to be great. And she, along with, Rosalind Grover really,
Mhm.
um, put their money where their mouth was.
They'll work. They don't just write a check.
No,
They put
and
in the work.
as Barbara said, and she told me, she goes, "This is the only place we can go to get care. So we've gotta make sure it's good. We have to make sure that it's good and that we're getting good care." And would hear her say that to my other patients when she was trying to squeeze pennies out of them. And, she was very effective at that, and so when heard her say that after being in really big cities and having, 4, 5, 6 options for hospitals, she was 100% right that, we are all are connected to the hospital in one way or another, and so it's incumbent on us to make sure that we're getting good quality care for our patients and for ourselves, our family members, and so, I will never forget that, yeah.
Yeah, I've repeated on this show, and every chance I get, I trumpet Roz's line during the campaign for tomorrow back in 2008 and 2009. She would tell people at fundraisers like, if you are diagnosed with cancer, you can make the choice to go to MD
Mhm,
Anderson. If you've want to go she would always say to go to Dallas to get your facelift. I don't know where you can make those decisions, but if your kid's in a car accident, if your
mhm,
wife has a heart attack, if your husband has a stroke, right down the street, this is where
mhm,
you're going to come. How good do you want our hospital to be? And it just that it. She probably said that in the first couple of months I was here, and I thought, wow, she really gets it. And
mhm,
we're not a level one trauma center. We're
mhm,
not all those things, but I think we're slowly making advances. And sometimes it feels like a couple of steps forward and then a step back. But we want to be able people to be able to stay close to
right,
home for their health care, for the things that we can do. We want to be able to do it well. There are certain things that we send out, but um, Doc Barbara Duke is absolutely correct.
mhm,
Like we need our healthcare system to be great. I think it's not just important to our health, but it's important to the economy.
right,
We hear that from the oil companies a lot. Like
mm,
I can recruit more engineers if we have a better healthcare system.
mhm,
I can recruit people to come here and live, and we're all in that battle together. And I think
mhm,
we're all working toward it in the same way, maybe sometimes at different speeds, but we're all in this together, try to
for
make our
sure.
community the best that it can be.
And it is a lot better in the 18 years that I've been here. I do see that we have a lot more access to primary care than we did. I was really shocked when I moved here that people had like 5 or 6 specialists but didn't have a primary care doctor. And so their care was a lot of times really fragmented or their medications were really confusing or, overlapping or contraindicated to take together. And so I do see, and I talked with Russell Myers before you about, beefing up primary care options. And I think that that has been a huge improvement of getting people more access.
I agree. Being in my role and in Russell's role, even when I was the CFO, the feedback we would hear a lot is the wait time to get into
Mhm.
specialists is too long. 15 years ago, we didn't hear, I can't get a primary care doctor. What we learned over time was people were using their specialists
Right.
as their primary care doctor.
Correct.
Our cardiologists were busy and jam
Right.
packed all day. and we discovered they're not doing heart care, which is what they're really
Mhm.
specially trained in. They build a relationship with the patient,
Mhm.
and they see them for everything. And so we said, "Hey, we need to let these patients go. We need you to
Mhm.
do heart care as an
Right.
example for a cardiologist." And they're like, "Where do I send my patient?
Mhm.
I'm not going to just let them go and not have them somewhere to go. And I want there to be a high quality physician that I can get them
Correct.
refer them to with
Mhm.
confidence." And so we have expanded primary care, and I think in doing that, that's expanded some access to specialty care. We still
Mhm.
have a lot of work to do. We have areas we can talk about. Urology is always
Sure.
at the top of the list. Neurology is a challenge for us that we continue to try to recruit in. But our general surgery group, as an example, I think it's as strong as any group that any large city would have. Their
Right.
capabilities, the way they work together and cover each other, we have some great coverage there.
Mhm.
We have some areas that we need to continue to work on. And then we always have to think about succession planning. We may
Mhm.
have a great group right now, but how old are they and when are they
Mhm.
going to plan to retire? Do we need to start recruiting today so that when that doctor leaves in 5 years, we're still in a good
Mhm.
position? So it's a battle that we all
Yeah.
fight together. And I certainly hear from physicians, hey, what are you going to do about this? This
Mhm.
guy's going to leave at some point, or we know they're planning to retire. And so I appreciate another example of that kind of relationship with the medical staff. Sometimes I don't know that somebody's planning to leave, but third
Mhm.
hand, I find out they're planning to retire in 2 years. We got to start
Mhm.
working today to get that replacement. You tell me a little bit about concierge medicine. Some people may not know what that is. Can you give us a quick?
Right. So, concierge medicine is taking kind of the middleman out between the physician and the patient. So, not taking insurance, and but having patients have complete access, meaning they have my cell phone number. And there's a bunch of different ways that people do concierge medicine. There's many different flavors. And there's other concierge physicians in Midland who practice differently than I do. But the way that I see my practice is kind of like you said in the bio, where it's old fashioned medicine. And, for the people who've been here a long time that know Dr. Bartha, I said, I want to be Dr. Bartha, but with just with cuter shoes. And so, but where, just providing good old fashioned medical care where I see people where they are, if they need to be seen at home, if they need to be seen in the office, if they're in the hospital, if it is directing their care to specialists in town, if we don't have that specialist here, finding them somewhere out of town, which, since I've lived a bunch of places is not too tricky.
Yeah,
But it's just having that really close relationship with a very small amount of people.
yeah,
And
I'm sure your patients really value that. It's probably not available for everybody to be able
correct.
to have that, but I think the patients that you have is great. So you take that insurance middleman out, and I know, for example, the hospital has a relationship with you, so
Correct.
all of your patients, they come to the hospital for
Mhm.
tests every year, and you pay us
Yes.
for that. It's out of that fee, and it works really well. So they get what they need.
Mhm.
But if they need a specialist, if
Correct.
they need a surgery, then their insurance, if they have
Of
Medicare,
course.
whatever, that kicks in, it's covered.
Of course.
But that regular access to you, it's I would like to say it's unique, but it's becoming very common. There's a lot
Mhm.
of concierge. As you say, everybody's a little different in the way they do it, but it's a common
Mhm.
structure now for
Correct.
access to primary care, and you get a different level of care. You don't
Mhm.
have to say, I feel a sore throat coming on. I'm going to call my doctor. We
Mhm.
can see you in 2 weeks. That,
Right.
that doesn't help whenever you feel the flu
No.
or strep throat coming on today. But when they call you, you're like, I'll be there
Yeah.
in 30 minutes and we'll check it out and I can get you a script. And
Mhm.
so it's a great service for our
Well,
community. So
thank you.
yeah, glad you do that. So let's talk about the 18 years that you've been
Mhm.
practicing medicine here in Midland. I'm sure that you've seen a ton of changes, technology, regulatory, whatever
Mhm.
it may be. Tell us some of the changes that you've seen in your time. And then after we talk about some of the changes, let's talk about some of the challenges that you
Mhm.
still see exist for us.
I mean, I think some of the changes have definitely been, more technology um in facilitating the care of patients. When I was at Texas Tech, it was paper charts still, and so that was actually really wonderful. And then when I went to Midland Family Physicians, they were in the process of I can't remember if it was their first EMR converting to an EMR, but it sometimes is clunky and sometimes it's slow electronic health record.
Yes.
I think that it in general is really great for making sure that there's a very comprehensive repository of patients' information. And I think that technology in a lot of ways, it's going to very much facilitate medicine being done in the proper manner. But it can be a pain too, because like,
Yeah.
at my office now, like everything is paperless, but sometimes our internet goes out because of the wind. And so
Yeah.
that's a real pain. But,
Yeah.
so I made sure that I picked an electronic health record that is completely accessible on my phone. So even if my internet's out, I can use cellular data to access the patients, which is not ideal, but it works. So, technology has been a big improvement. And, when I first moved here, there weren't people doing robotic surgery.
No, we didn't
And
have a
so
robot when you got here.
correct. And so now that there's not only one person doing robotic surgery, but several in a
Yes.
lot of different specialties,
Correct.
gynecology, urology, general surgery. I
Those are
can't think,
probably the 3.
well, orthopedics also.
Yeah, they don't use a Da Vinci robots, what I
Right.
was thinking of, but they have the 2 Mako robots, that's
Correct.
right.
And so that has been a big change. It's been in every industry, but in medicine as well. But that's made a big difference with patients' recovery time. I when I was in training, when patients would have an open hysterectomy, they'd be in the hospital for a week, maybe more. And so now patients do it outpatient.
They do.
And so they leave the same day. And so their recovery is much better. Complication rates are lower. So those are things that are definitely helping to provide better care to patients. As far as other changes, just having more specialists. When I first came here, we had one hand surgeon who was kind of retiring,
Yes.
and now we have two or three really great
Yeah,
hand surgeons.
yeah.
And people that not only are good at what they do and are very well qualified and well trained, but are also really nice. And so, people that we can call in a pinch when we need something, like when my son breaks his hand playing football. Yeah, you
Yep.
call your local hand surgeon. Yeah.
Yeah, yeah.
Um, and I'm trying to think of other things that are improved. I mean, just in general, more specialties. Now we have Dr. Neil Shaw is here, who's a stroke certified neurologist, which is fantastic. I mean, the hospital's gotten by with having teleneurology from actually UT Houston,
Yes.
that provided teleneurology services, and which has been really great and has, provided patients the care that they need when they're having an acute stroke in the emergency room. But having Dr. Shaw here now has been revolutionary. I mean, it's been really great for people that have had complex strokes that I've kind of had to keep with a neurologist somewhere out of town. And now having him here transferring their care back into town has been great.
It's great for patients.
Mhm.
It's great for the hospital and the community. Certainly, Dr. Shaw's a great story. These are the stories I like. He knocked on our door and he
Mhm.
said, "My spouse is getting transferred to Midland. You guys looking for neurology help?" I wish we could get more physicians that way. We usually have to recruit for years to get them to commit to come here. But yeah, he's a
Mhm.
great addition for us. And the technology is the obvious thing. That's why I
Mhm.
said that. I think whatever industry you're working in,
Mhm.
if you're thinking what's changed over the last 20 years, technology's driven all of it. But your EMR heartache, I certainly share that. We were on paper for a long time, of course, and then we moved to the old VA system is what we had. You were probably just starting your practice when we had the
Mhm.
old, we called it Edith, and then moved to Cerner, which is now owned by Oracle. I think it's great advancements in care, but there's no panacea.
No.
None of these things are perfect, and they make my life better and whole. They improve some things. They probably have some
Yeah.
drawbacks in other areas. We get complaints from our nursing staff, from physicians and patients alike about the EMR and access to their portal. I think we're moving the ball forward, but clunky, I think was the word that you used. Sometimes
Clunky.
it's not as
Yeah.
seamless as we would like it to be, but I think it's moving in the right direction. But
Mhm.
I don't see a panacea out there.
No, and I think it's great for, my younger patients for sure when they can access their radiologic records through the hospital, which that's new and that's been really great. But I also, on the other hand, take care of a lot of elderly patients or people who are a little bit older. And as one person said to me today, he goes, "They've just left me behind," because
Yeah,
he doesn't know how to, check a text message to look at his lab orders from another provider, or to, everything. If you have to log in online, that can be very cumbersome for some people. And so, luckily in my practice, we have time to help people do their registration for other offices. But I think that that's something that, all practices should be aware of and give people options that maybe people that are, of a certain age or just not technologically capable or savvy.
sure. And so you want to have whatever it is, whether it's access to medical records is a good example. You want to make sure you're taking care of those people in the sunset years of their life that don't have a cell phone or don't have a computer or don't know what Wi-Fi is. You've got to have that old school way to take care
Mhm.
of them if they need to go to another provider and they need their records. How do you do that? But you also have this younger generation is like, I don't want to come to the hospital. I don't
Yeah.
want you to give me a piece of paper.
Yeah.
I want you to send it to my phone, and
Don't even call
I
me,
want to be
text
able to
me.
tap something at my new doctor and everything just go over there. Like, I'm
Mhm.
not coming in. And so how do we balance
Right.
that all the time? And it's a consistent struggle for us because
Of
I think,
course.
oh, we've made progress here. And then somebody says, well, in that progress, you've stepped back from this other group and you
Mhm.
haven't helped them. And so it's a constant battle. But I think overall technology is a good thing. There are
Mhm.
some evils in it that we all battle, but I'm glad we have it. I think it
Mhm.
makes healthcare better, but it's certainly not perfect. And we have to keep in mind that
Mhm.
there are people that didn't grow up with a cell phone in their
Mhm.
hand, and they don't know how to use it that way. And we got to keep that old school medicine still
Mhm.
available to that group.
And I think a challenge would be pharmacies, that there was a big change in pharmacies during the pandemic or right after the pandemic with hour restrictions. And so I know that that's always a big complaint in the community. And I mean, a legitimate one if you can't get your medications filled overnight when you're leaving the emergency room.
Sure. On
And so,
holiday weekends, the
right,
example I've had, I can't. I'm
right.
I'm in the ER on Friday night. Monday's Labor Day. I'm not going to get my script until Tuesday.
Hmm.
That's a big problem. There's a 24-hour pharmacy in Odessa, but there's not one in Midland.
I
I've
know.
talked to Walgreens, I've talked to CVS, and they've all told me to go jump in a lake. They're not bringing a 24-hour pharmacy. We're trying to address that,
Hmm.
not necessarily in full, but we're building up our retail pharmacy so we
Hmm.
can make sure that people leave the ER and inpatient discharges can leave with a script so they
That's
don't
great.
have to worry about that. That's a step in the right direction, but there are still people that aren't in the hospital
Right.
that, that your patients are a good example that you
Hmm.
may follow up with on a Friday night.
Hmm.
Now they need a script. There's really nowhere for them to go. I hope that our hospital will be able to fill that void in the future. We're just opened a couple of months ago and are trying to step into this meds to beds, but that's a major problem.
Hmm.
I've quoted this a lot. The number one reason people get readmitted to the hospital after discharge is because they don't take their medications.
Hmm.
Sometimes it's because they don't have access. Sometimes it's because they can't afford it. We've had instances where people said, "I didn't know this had to be refrigerated. I don't have electricity in my house."
Hmm.
So I was able to take it for a couple of days, but after that, it was bad. Those are all real
Right.
problems that our community faces, just like everybody else. So access is the first thing you got to have, and we're working on improving that. But there are other social factors that can
Correct.
contribute to that as well. So you meant you were jumping into challenges with the pharmacy as a good example. What are some of the challenges you see, and certainly from a physician's perspective? I know your perspective is that of your patients, but what are some of the challenges for healthcare in our community? What are things that the community can do better to attract physicians and medical professionals? What are things the hospital needs to work on and do
Hmm.
better to be in a like for physicians to say, I would love to practice
Right.
not just in that community but that hospital.
And I think that what was strange to me moving here was there's just always been a lot of community chatter about things going on at the hospital. Like when I first moved here, people talked about infection rates all the time. And so of course that scares me
Sure.
because I don't know any better. So then I look into it and think, oh, well, no, actually that's not really true. Or, anybody who goes in for this procedure comes out maimed. You hear those wild stories all the time because if it's at church or,
Yep.
at dinner with somebody. And so having to look into those as a physician and thinking, do I want to live here? Do I want to practice here? Like, is this safe for me to be here?
Sure.
And knowing that those are pretty much just old, tired myths,
Yeah.
basically.
Yeah.
And so that's a challenge of getting people who've been here for a long time to realize that that might have been true 20, 25 years ago, but there are, so many advances that have happened. And for example, like our joint and spine center has extremely low infection rates. And so I think that the challenge is overcoming the myth,
Hmm.
but then also too, I think the hospital needs to be a better advocate for itself on the things it's doing well. And you and I talked about this, whether it needs to be on, social media or, because people will get on TikTok or YouTube or whatever and say ridiculously wild things about the hospital, which might have a grain of truth in them, but
Sure.
maybe not. And then that spreads really, really fast. We all know bad news spreads at 8 times the rate of good news.
Sure.
And so how do we put out the good news of, the great things that are happening and all the ways in which our patients get really good care and how, had a patient, have patients all the time that get excellent care from Midland Memorial, but nobody really talks about that. You just hear the very explosive stories of things that went awry, and that may or may not be due to the care at the hospital. And I think that all hospitals have ways to improve. Do not get me wrong. Every hospital can improve, quality, can improve staffing, all of these things. There are challenges everywhere. But I think that the challenges now are different than the challenges were 20 years ago.
And that's a good thing.
Yes,
That's a good thing that we're not focused on the same things that we were
correct.
talking about a long time ago. But I'm very defensive and biased, obviously, of the hospital. But
Mhm.
I think one of my biggest strengths is self awareness and awareness. Like we're not perfect. We
Right.
do. I agree with your grain of truth comment. Like I think all these old myths or wives' tales, they're probably grounded in fact at some point,
Sure.
but they're old stories that have been passed down
Sure.
from generation to generation, and they're just not true anymore. And it's a challenge. That's one of the reasons that we
Mhm.
talked about the podcast. You talked about social media. Like That was a common feedback I've gotten from the medical staff, Dr. Merritt specifically, is you've got to do a better job of telling the story of the hospital. How are you
Mhm.
getting messaging out about the things that we're doing well? Um, and so we've been working on that. We're working on Google reviews. We're working on a redevelopment of our website that makes it easier to navigate and find things. We're doing this podcast to try to get information out. We've got a whole podcast coming up next month that's just based on infections. We're going to have
Mhm.
Val Sparks
Oh,
and come
great.
in and talk about what are
Mhm.
the things that we track. Where do we do well? Where do we not do well? I'm open to having difficult conversations because I know we're not perfect and I know we need to improve. But I think and I think the medical staff and I think the people that are close to the hospital know, like, we certainly want to improve. Like, we're driven to do
Mhm.
better. We know we have shortcomings and we're trying to tackle those things. But I think you're right. All those things are grounded in truth, but they're just not true anymore. The people's feelings are valid because they heard that from somebody that it was based in fact, but it was 20 years ago that that happened.
And I mean, I mean, at any hospital, there's going to be things that maybe get missed, that maybe get misdiagnosed, that maybe don't get treated appropriately, and that's going to happen anywhere. But I think that since we're Midland Memorial's the only game in town, that you're going to hear those stories over and over again.
Yeah.
And of course, I heard those in Dallas and Houston, but there were people to compare to.
Yeah. It was spread out amongst
Correct.
18 hospitals
Yeah.
within a rock throw from each
And
other.
I know that, our patients do, a challenge I think can be intermittently the ER wait times. And I think that that's been a problem in the past couple weeks even
Yeah.
where, the hospital's been really full. There haven't been places to admit patients, that need a bed inside. And so then it slows down the ER. And I think that you were obviously very aware of this. And, that's something that we hear feedback as community physicians is, should I just go to Odessa? Is the wait time going to be any less there? And so I know that, between you and the ER leadership are working on addressing those problems.
Yeah, I think the biggest problem with our emergency room is it's really a lack of beds. I think more often than not, that's the problem is people get backed up there because we've got 10 patients waiting for a bed, but we're full upstairs. And that's something that we've talked about just in the last couple of months with our planning committee of our board is we really need to expand our beds and our community's been very supportive of us finding the money and the time and the space to
Mhm.
build additional beds. I'm confident that we can do that, but that comes with a lot of other caveats. We need more
Sure.
nurses,
Yeah.
we need more physicians, we need more pharmacists, we need more respiratory therapists, more lab technicians, you name it. Like, the workforce is the real challenge. We hit
Mhm.
a little bit on that earlier, but getting the money to build beds, that's probably the easiest part. It's
Right.
staffing it, making sure we can have those beds open every day. I've said the last 2 years, calendar year 24 and 25, we declined over 2,000 transfer requests from the region, small regional hospitals around us that don't have the capabilities that we have that called us and said, "Hey, I've got a sick patient. I need to send them to you." And we said, "We can't take them. We
Mhm.
don't have beds." So the need is not just in our ER,
Mhm.
it's also out in the surrounding community, which we feel an obligation to. And talking about the complaints and, concerns, yeah, I think we're blessed with that because I think people feel ownership of their hospital as
Mhm.
they should. We're a hospital district. People pay taxes to our hospital. Everybody does that owns
Mhm.
property here, so they feel ownership and they want it to be great. And so sometimes you know that you hear these complaints and they drive you crazy, but it's really a blessing to have the community that engaged in the healthcare that they have, and our community is very supportive of that. So there's not a lot of excuses. It takes time to make these changes, but I can't just shrug my shoulders and say this is just a battle that we can't
Mhm.
overcome because the day I say that, I should probably pack my bags and leave because there are people in this community. If you go and tell them, here's my problem and here's the solution, and I can't do this
Mhm.
on my own, we know there are a lot of people
Right.
that'll sign up to help for that. And that's the blessing of living
Mhm.
in Midland. So well, thanks for sharing those challenges. I think they're real and they're constantly things we can improve on. And having the medical staff at the table for those
Mhm.
decisions and solutions, I think are key to making it really seamless for everybody involved. You talked a little bit about recruitment. We both talked a little bit about recruiting physicians to Midland, which whether you're talking about recruiting physicians or teachers or police officers or firefighters, I think the
Mhm.
challenge is not unique to healthcare.
Right.
It's really across the board. But from the medical side and friends that you have, what are the issues of recruiting physicians to Midland, and what can we do in our community to make this really attractive for people to
Mhm.
relocate here or after they finish school to move here and start their
Right.
practice?
I mean, I think it's like you said, the challenge that any industry would face. I mean, we love it here. Obviously, I've been here a really long time, but it is not the easiest place to always to live, especially like it's not that pretty. There's not as many restaurants. There's not as much entertainment. And so when people are in medical school or, finishing residency and they can go really anywhere in the country, it's a little bit tricky to sell Midland unless they have family here or have been here before, just because we're landlocked and geographically perhaps undesirable.
Challenged,
Yeah.
yeah.
So I think that's tricky. And I think that getting people here, I mean, I think physicians need to know that they have a really robust medical staff of colleagues who are very supportive of them. They need to know the hospital is very supportive of their practice and not just getting here and recruiting, but also, helping them to grow their practices, helping them to be supported if they want to start new procedures or new service lines, that originate with them. But then also just checking in on them and making sure that their quality of life is good, but also just the way that they're treated by the hospital administration is something that's always being addressed. And so, because I have seen, people who get get recruited, but then maybe only stay 3 or 4 years, and that can be for a variety of reasons.
Yeah.
Some of it is they don't have the access to schools that they want. Several of my friends have left because they wanted their kids to have very specific opportunities in high school, and Midland doesn't have those offerings. Um, and sometimes, as in anywhere, people just have changes to their life, and
Sure.
their spouse or their partner might get a job somewhere else. And so I think that Midland can be a tricky place to come. And then sometimes it can be an easy place to leave, if that makes sense.
No, I think you're right. I share your feelings in that I got settled here, and I thought, well, Monica and I'll get settled here, and I'll get a little career underneath me, and then we'll leave,
Hmm.
obviously, and we'll go do something else. But
Right.
really fell in love with the community. When I hear those things from people about, well, what it doesn't seem like there's as much to do here, or maybe there's not a cheesecake factory. I mean, I try to combat that with we have great restaurants.
Yeah.
We don't have maybe what there is in Dallas, but there
Hmm.
are places we love to hit all the time, and we have the Wagner Noel, and we have a great airport.
Hmm.
It's really easy to get in and out of. If
Hmm.
you want to get away for a long weekend, we've got Southwest direct flights everywhere. And then it's a great place to raise a family.
Yeah.
That was over and above why Monica and I decided to stay here. Is
Hmm.
we're like, we really want to raise our kids in this kind of a community. I don't
Right.
want to get lost in Dallas or Austin or some big community. So you try to counter those things with, but it depends on where they are in their life. That
Right.
might not be attractive to some providers that we're trying to recruit at all. Other people, I think it does make a difference, and I think that's why a lot of people stay. It's not because we have a cheesecake
Hmm.
factory or there's a lot of things to
No.
do. There are other things in their life that are important to them, and so some of these things we can work on. I
Right.
think the community's been working on that for a while.
Hmm.
There's a lot more to do here than there used to be.
Right.
We have more restaurants than we used to have. I think everybody's kind of swimming in the same direction to make this community more desirable. But there are also things I think that are really difficult to overcome. That we
Right.
can't grow trees and build a lake and
Sure.
do some of those things. So, um,
And that's what I always tell my friends who are other places that, say, come back to Dallas or come back to Houston. Why are you still there? And I just have to tell them because it's easy. When my kids weren't driving, or I would take my son to school and I'm there in 7 minutes. And so I could take him to school every morning, be to my office. Sometimes I run home during lunch. My physician colleagues in other places, sometimes they might be on staff at 3 different hospitals. So it might mean that they go round at one hospital in the morning, then they might go to their clinic, which might be 20 or 30 minutes away, and then they go operate somewhere else, which might be an hour away. And then if they have to go back to clinic, so they might be commuting a couple hours a day. And a lot of my physician friends that are on the East Coast or West Coast, might have 2 nannies to be able to manage because they're gone so long and they don't have a 7-minute commute
yeah.
that
And think about those 2 hours they're losing every day. Think about
Mhm.
access to care. If they could be in their office for those 2 hours a day, how many more patients could they treat? Whether you're in Dallas or Midland or
Mhm.
South Dakota, it doesn't matter.
And it
It
doesn't usually eat into patient care time, but it does definitely eat into their family
Yeah, they've
time.
gotta expand
Right.
their day to be able to get all the work done that they need to get done, and so there's a work-life balance there, and then
Mhm.
you can talk better than I can about physician burnout, and that's a real
Mhm.
thing.
No.
All the regulatory things that the government puts out and those days extending from what used to be 7:30 to 6 is now a 6:30 to 8:30
Mhm.
PM, and you gotta do charting after the fact, and you gotta go check all these boxes because if you don't, insurance won't pay you.
Mhm.
It's so difficult, and
Mhm.
you're right, the access to care, I think, is impacted, but it also just impacts your day and
Mhm.
how much time you have to do other things that we
Right.
all like to be able to do, and I think that's what's driving physician burnout, and I think that's something that Midland can do to say, "This is an attractive place. We can
Right.
make your practice easy, we can make it work, we can make sure you get home at a decent hour," And that's a great I've made that point too. I could go to my kids' program at Hillender School at 10:30 in the morning. I'd be back at work at 11.
Yeah.
In Dallas, it's like there goes half my day.
Right.
If I'm going to try to go to school and watch a program, those are some of the benefits of living in Midland. What we really have loved about being here.
And it's also just easy as far as, I can go run 3 errands in 30 minutes, whereas that might take me an hour and a half somewhere else.
Yeah.
And so it's easy. And that's what I tell my friends over and over again. It's just easy living here.
Yeah.
And, with, everything's so connected in a good way and easy in the way that, my patients are my friends, that some of them feel like my family. I call my patient panel my big dysfunctional family. And so in that way, it's easy to be here because just like I know that there's physician colleagues that'll help me out in a pinch. I have patients who will help me out in a pinch. And that's where I don't know that I could have that same experience somewhere else.
Yeah, it's that small town feel again.
Mhm.
Like everybody's your neighbor, everybody knows what everybody's doing, and you build a kind of a kinship that you may not get in other places. I feel that as well. Let's move on. So let's talk about how physicians are kind of involved in governing of the hospitals. Do you have relationships with the boards, committees? You're the chief of staff of the medical. Tell people how physicians are involved with
Sure.
me and with the boards in governing what the hospital actually
Sure.
does.
So there's the general medical staff, which is 400 plus
Yeah.
physicians, I think. And so some of us who then volunteer for positions, we volunteer because we care.
Yeah.
And we want to work together, and we're already all working together to take care of patients. And so, of course, then we're going to work together to help move healthcare forward in Midland. And so there are a bunch of different committees for a bunch of different reasons that all hospitals have, for quality reasons, for bylaws reasons, and then every
Credentialing new
credentialing,
physicians.
and then every department has a department chair, and then every department has a section chief. And so then once a month, we all have a meeting called the medical executive committee meeting, where we meet with hospital vice presidents, so finance, chief medical officer, chief nursing officer, and
Quality's there, VP of
quality.
quality, and Wes, VP of ancillary
Yes,
services. Yeah.
okay. And so we all can touch base and talk about, what's going on, what issues that we're having, what issues not we are having, but what issues our patients are having, and ways in which that the hospital can work together to be a better place to be able to provide care to our patients. And so that means, sometimes there might be 3 meetings a week. And then sometimes there might be more or less, and we're all talking all the time.
Sure.
But then as chief of staff, then I report to the board of trustees once a month, as you do, just to kind of give an update on what medical staff is working on, whether that be quality indices or just giving updates as far as changes in the hospital, like the emergency department, or how the medical staff in the fall thought it would be very important for patient care for there to be a 24-hour ICU physician staffed. And that was the change that we brought to you and you
You
were
did.
able to make happen,
Yeah.
because we do feel like that'll really help overall quality in the ICU, because if anybody is acutely ill in Midland, they're going to end up in the ICU. And so we want to make sure that there are board certified physicians there 24/7. And, our neurosurgeons thought that was very important. The cardiologists thought that was
Yeah.
very important. And when you look at quality scores across the country, that is one of the linchpins in making that quality improvement happen in ICUs, is having board certified physicians there 24/7. So we're really, really excited that that change has come to fruition, or will in July.
Yep.
Um,
I
and
think our patients, anybody who ends up in the ICU would say that's really important too.
right.
To have that physician in there 24/7 is really a game changer for us. And I'm glad we were able to make that happen. We've got a recruit that'll be here in just a couple of months, but that'll be a new thing for our hospital. And I do
Mhm.
think it'll really up the game of the critical care department. But I think that there is a effect there that I think it lifts the game for everybody
Right.
else, having that kind of presence there.
Right. And I think that also too, maybe more than a couple years ago now, within credentials committee, thought it was important that all physicians on staff be board certified or board eligible.
Eligible. Yeah.
And so there are some people who are grandfathered in who may not have had board certification, but there are colleagues that we've worked with for decades and they're wonderful. But any new physician coming in, we find that it's very important for people to have those board certifications, which means they have to we sit for really long tests, and then have to stay up to date with getting continuing medical education hours, and then either recertifying tests or submitting case logs. So that way our certifying boards know that we are staying up to date. And so we feel like that is something that we can hold each other accountable to, is staying board certified, because it brings up the level of care, like you said, for everyone.
Yeah, I agree. I think, I think it's important to note we have on our board of trustees, we have two medical staff positions. You guys vote and appoint
Correct.
with the governor's sign off to put two medical staff members on our board. So they're in the board meetings every day. There's nothing happening, kind of in a dark smoke filled room without physicians being involved. And the thing we did in the last few months is we've appointed two retired physicians onto our board that still care about the health and wellness of the community. But they're not. It sometimes can be tough to show up to a board meeting when you're a practicing physician. They
Yes.
happen during the lunch hour, and you never know what's going to happen from
Right.
day to day. So having these two retired physicians, Dr. Welsh and Dr. Oliver, who joined the board in January, I think will lift the game of the board.
Right.
Having people with that kind of knowledge to kind of challenge the board, challenge the management team to say, hey, these are things you need to be looking at. I think is going to be really tremendous as well for us. And then, the board delegates most of the medical responsibility to the MEC, the medical executive committee you talked about. They have ultimate authority. They sign off on all those things, but most of that goes through you guys. And if you approve it, it comes to the board kind of as a
Mhm.
consent item. And they trust you guys to kind of lead and that's the way it works in most hospitals. That's not
Right.
unique to Midland, but I think it kind of creates that kind of shared stakeholder approach where we
Mhm.
all have skin in the game in this, and the performance of the hospital and what we allow to happen in here and things that maybe we purposely try to keep out. We make those decisions together. I'm not the ultimate authority on that. The board isn't alone in those kind of decisions, and the medical staff can't do that on their own. Appreciate your work. You talk about those weeks where you have sometimes there's 3 meetings. I don't know if you knew what you were getting into when you became chief of staff,
Not
but
100%, no.
it is a busy job, and it's
Mhm.
but as you said, what happens in the hospital is important to your patients. So thank you for serving on that. Let's wrap up today and tell me what you are most proud of in practicing medicine in Midland, and what should our community know about the medical staff that is here to serve them each and every day?
Okay. So I would say what I'm most proud of is, well, the reason why I do what I do is because of the relationships I have with patients and being able to watch out for their health in acute events, but also, long term in prevention. But I'm really proud of our medical staff and the way that we work together. And it's because we're the only ones here. And so we might as well get along. And so not only do we get along, that we're actually really good friends, a lot of people in a lot of different ways. And, I don't know that in other places I could text people and say, "Hey, I have a question," and I call it phone a friend. Where sometimes I'll call and say, "I'm having a really hard diagnostic case. This is the deal. This is what I've ordered. This is what came up. What do you think I should do?" And never once do those physicians say, "I don't have time for this." They don't say, "Wait,
Send them to the
what's the
office.
patient's insurance? What's their
Yeah.
copay?" That they help me to figure out how to better help my patients. And sometimes it's a, "Yeah, I probably need to see him. Can you send him over whenever?" Or, "Hey, order this first and then I'll see them." But I think that our collegial relationships are, I'm really proud of those. And even when we don't agree and we fight, about different
Healthy disagreement.
we fight, they disagree. So we'll have these about things that go on administratively in the hospital, because we don't ever usually agree, even in the medical executive meetings, because everybody's coming from different perspectives. It might be, anesthesiology or surgery or emergency room medicine. Everybody has different perspectives on the way they're delivering medicine. And so sometimes those are in conflict. But I think that the way that we all want patients to have really good care, we want our hospital to be really great. We do have that shared vision for the hospital. And so I'm really proud of them. Sometimes if there's technological failures that happen with getting patients referred, that sometimes we call each other, or we just say, "Hey, I think you saw this person already. What'd you find? What do I need to do next? What do they need?" And so that's always really great to know that we know each other. And not only do we know each other within the hospital, but, people play golf together
Yeah.
and they
Our
go on
kids go to
vacation.
school
Yeah,
together. We go to church together.
exactly.
Yeah.
And so those are all, there's always, it's kind of like the Midland connection where it's never 9 degrees of separation. It's usually two.
Yeah, it's
And
close.
so that also is what happens with the medical staff.
Yeah, I share your pride in that. I see, I the healthy disagreement and conflict. I think that's good from time to time, and I certainly have physicians that come into my office and yell and say this isn't working. It's got to work. You're impacting my patients, and I take all that seriously. But I always go back to, even in times of stress for me, I think about the pandemic. I think
Mhm.
about the steam issue that we just had with our
Yeah.
our steam delivery system being down. You know, when we're in a real crisis,
Mhm.
man, you guys line up at my door and say, "What can we do to help? Have you
Yeah.
thought about doing this?" You're offering ideas. Like, the way we all work together in a real crisis, uh, really just is inspiring, and it makes you happy to come to work every day, even though you have those days where things are going pretty well for the most part. So you feel like you're having a debate about something that's minor in comparison to these other things, but you know, these people really, they've proven that they care about the
Mhm.
community, they care about their patients, they care about the hospital. It's really important to their practice. And so sometimes you have those moments and you're like, you know, I remember yesterday when I was in crisis and those guys lined up to help.
Mhm.
And so those are the things I think we all remind ourselves of, probably when you have conflict with one of your peers. But you know, last week I called and he got on the phone with me and he walked me through it. And so we help each other. And again, all comes back to that Midland perspective. I think that's what
Mhm.
makes our community so unique, is we have those kind of relationships. As we said, both of our sons play baseball. Like, we have all these connections, even if we don't hang out and have dinner once a week. We're all close and we share our community pride,
Mhm.
our school pride, the pride in the hospital. We all want it to be
Mhm.
better, but we have alignment around those things. And I
Mhm.
think that's what makes the medical staff special. I think it's what makes Midland special.
And I think too, for sure, that's definitely correct. And also, if you ever go look at the credentials of some of the people who are practicing in Midland, they're outstanding. And so I've, had a patient who was having an issue and said, I've got to go to Dallas and I want to see this person in Dallas. So I pulled up on the internet and pulled up that person's credentials. And then I pulled up a physician colleague in Midland and said, who do you think is better trained? Let's look at these. And
Yeah.
they were shocked.
Yeah.
They were absolutely shocked that that person was in Midland that had trained at Hopkins or Mayo or wherever it was. That yes, we do come back here and we stay here, and we are just as well trained or better trained than people in other locations,
Yeah.
other cities.
I think working the management team and the medical staff working together, I think we all agree we need more physicians,
Of course.
but I think we work really well, and we don't allow just any physician to come in and get credentialed here and treat our patients. Like, there's a pretty rigorous process that a physician has to go through the hospital process, through the medical staff credentialing process, and then get approved by our board. So the guys that we have here, guys and
Mhm.
gals, are extremely talented. We
Right.
don't just let anybody come in. That's one of the reasons I think we need more physicians, is because we are picky. We want to make sure you know that whoever you credential at the hospital, you may need to call or send your patient
Mhm.
to, and you don't want it to be a substandard
And
provider.
I don't know if the community necessarily realizes that, when a patient, or I'm sorry, when a physician comes here, they have a packet. And so the person is not here in person. We are looking at all their information. And we have a really great medical staff services team led by Rebecca Pontaski. And so her team looks into this person, doing background checks, calling old references, getting information from boards, pulling up malpractice claims. And all of those things are looked over with a fine tooth comb because we don't want to bring someone here and credential them who's going to harm our patients. And there's been in the past, we could have very easily hired physicians in subspecialties of need, but we did not have quality candidates who we felt comfortable working with.
Yeah.
And so it's almost a disservice to the physicians who are here to bring it is to bring them
Yeah.
here, even if it means that we're working short staffed in certain specialties. We'd rather have somebody well qualified who's going to take good care
Yeah.
of our
You'd
patients.
rather send your patient to a well-qualified doctor in Dallas than to have a substandard guy right around the
A
corner.
hundred
Yeah,
percent. And that's what we all
we
say.
all agree on
Yeah.
that. Like, that's just another example of how we all work together and try to protect the health in our community, always working to advance it. But I appreciate your leadership on the medical staff. I've really liked getting to know you the last couple of years. This is your last year as the chief. You'll be on the medical executive committee for a while. I really appreciate you coming on. I think it's important to have a physician come on and talk to our community about that perspective of what we're doing well, what we need to work on, and some of the challenges that we face. So, thanks for coming on. I really
Very
appreciate
welcome.
it. I think this will be very well received by the community.
Okay, great. Thank you for
So
having me.
that'll wrap up our show today with the Midland Health Podcast, healthcare that makes you proud. Remember, subscribe to the channel. Leave a comment if there are topics or guests that you want to see us bring on. We're going to do this through December of 26. See what kind of engagement we get, and then we'll determine if we want to keep doing this into 2027. But we appreciate you watching the episode today. Thanks.